I just want to give you a warning. I'm going to be using a lot of slides, but I'm just going to be saying one sentence for each slide, just to give you, because that was my sort of marching orders, to give you an overview of the work we have done so far. And of course, we're talking about 20 years of research and development and encouraging innovations and so on and so forth. So I'm just going to be saying a quick sentence for each slide. You have the handouts, you have the links, you can find the published research online if you wanted to, or if you reach out to me, I'm happy to sort of point you in the right direction. But let's start. So my name is Majd Alwan. I'm the Senior Vice President of Technology and Business Strategy at Leading Age. I'm also the Executive Director of the Leading Age Center for Aging Services Technologies. And the center, for those who are not familiar with it, it's a program of Leading Age, and Leading Age is a 501c3 not-for-profit association of aging service providers across the whole continuum, from home health and home care all the way to skilled nursing facilities. My background is in engineering. I came to Leading Age from the University of Virginia, where I was an assistant professor of research. And my research there started with creating a new paradigm that is technology enabled, a paradigm of care that is technology enabled, that sort of uses sensors embedded in the environment to monitor the older adults' health and functional status, well-being, sleep, and so on and so forth, and to try to deliver preventive and proactive care through professional care providers or family caregivers. And we have done a lot of sort of designed the system that was used using a user-centered design approach, as Dr. Grimm mentioned in her sort of presentation. And we focused on, and we looked at the whole stakeholder groups, the older adult, the family caregiver, the professional caregiver. And not only did we look at their needs and what's useful, for example, for the caregivers, but also what's acceptable and what modalities of sensing are acceptable. So that's an important thing. We decided to go with knowledge engineered inference engine to identify the occurrence of activities of daily living, which are, by the way, the method of assessing need for moving to skilled nursing facility or needing higher levels of care. Of course, we validated the inferences using an acceptable way of a personal digital assistant diary that we gave the user to make it easier for them to to help us verify our inferences. We didn't stop there. We also tried several stochastic and machine learning ways, because we were collecting a lot of data, lots and lots of data from a user that was living in a fully censored smart house. And but we didn't we ended up sticking with our knowledge engineered rules because they performed better than many of the methods, the automated learning, machine learning approaches that we tried. One of the unique pieces of technology that we developed was a pad that can detect vital signs as well as movement in the bed. So we can detect heart rate, breathing rate, variability in both, as well as movement or restlessness in bed. And of course, bed exit, which could indicate risk for falling. Body temperature, and we were starting to experiment with measuring blood pressure. We didn't get there. So, but we were able to create a system that can help identify sleep stages passively, completely passively. So the approach was to embed sensors in the environment, not have the older adult wear anything special or do anything out of their ordinary routine. Of course, we validated this against polysomnography, against actigraphy in the home. We also developed another piece of technology. It's a floor vibrations-based fall detector and gait monitor that can detect the heel strikes and count steps, detect shuffling, and so on and so forth. And of course, it can detect falls and can distinguish from dropping an object versus a multi-limbed sort of articulated body falling on the floor. We validated it in the lab and tested it using the Rescue Randy, which is used to train firefighters. The other piece of technology, being a robotics engineer from my PhD work, we also worked on assistive devices, primarily focused on assistive walkers. We developed a walker that can help individuals with macular degeneration and depth perception and other sort of vision issues among the older adult population navigate tight spaces within the environment. And in the second iteration of that walker, we installed force and moment sensors on the handles of the walker to make it more user-friendly and more shared control, to make the user feel that they are still in control rather than sometimes fighting the walker if they are facing an obstacle. And lo and behold, when we did the testing in the gait lab using the gold standard of gait assessment, we realized that the moment we measured from the handles actually reflected accurately the heel strike moments. And we were able to derive a complete set of gait characteristics, as well as a balance index that would indicate whether the walker is no longer safer for the individual. They may need to have more rehabilitation before continuing to use the walker, or when it might be sort of too much, they may need to be upgraded to a cane or walking sticks. So that's generally what we did. We also partnered with aging service providers to test in the field those types of systems. And we tested this configuration that you're seeing on the screen in a variety of care settings: assisted living, independent living, in the home, and we learned a lot. And we did those evaluations again in partnership with the providers, and we did sort of an objective evaluation of the impacts on many aspects, the cost of care, efficiency of caregivers, and so on and so forth. As well as and we've shown a significant reduction in payments to providers, to payers, cost savings to payers. Back in 2012, if you remember the HITECH Act included a mandatory study and a report to Congress. And I was the co-director. I had the honor to be co-director and the co-editor and co-author of several chapters on the most seminal, probably, study of the aging services technologies and their premise for older adult and individuals with disabilities. But we looked at things from the perspective of care issues as opposed to genres of technologies. And we selected 8 of the most sort of costly and burdensome issues that are affecting this population. Again, we did one of the things that we did after I moved to, I was recruited into Leading Age, is a sort of starting to create and evangelize a vision of how technology can transform the paradigm of care. And first we did this back in 2005, and maybe Claude, you remember the first video with Jeff Bridges, which was done using technologies made with computer graphics, but the 2012 iteration was used or implemented using actual technologies on the market. One way we thought about or tried to encourage continuing innovation in this field was we organized and ran our own hackfest or accelerated development event during our annual meeting. We insisted on having multidisciplinary teams. We insisted on having representation from A, the provider community, and B, the professional caregivers, nurses, therapists, etc. And we insisted again on the multidisciplinary, including a person that is a marketing person, as well as a business and business modeling person, and so on and so forth. We ran this for a few years, and it was a great success. But again, it wasn't tied to a venture capital or angel sort of investors. So not many of these activities continued afterwards. So the other things that we do on a regular basis is surveying our members regarding their technology spending technology spending priorities, and also measuring the actual technology spending biannually. We also measure the adoption of technology annually. Again, popular categories of technologies from electronic health records all the way to safety, fall detectors, and so on and so forth, including health information exchange or participation in health information exchange. We also recognized in 2016 that we need to better understand not only the adoption rate, but the sophistication level of the different EHRs being adopted. So we've adapted the HIMSS 7-stage EHR adoption model to fit the long-term and post-acute care sector. And we survey vendors who are participating in our EHR selection tool, which I'm going to be mentioning, one of 9 tools that we've developed and keep up to date. We measure the sophistication of the EHRs being deployed in reality. And as you can see here, we're seeing over the past few years, we've seen a significant increase in the most sophisticated stages 6 and 7, and a significant reduction in the less sophisticated, the basic EHRs. So how do we encourage adoption? Well, what are we doing to encourage the adoption? Because a technology innovation that is not adopted is as good as dead out of the gate, right? So we recognize that our members need to ingrain technology into their strategic planning, tie their strategic goals to key enabling technologies, and then start preparing their information and communication infrastructure to be ready for layering the different technology applications. And they need to be thinking about it holistically. They need to be thinking about it in terms of integration, integration between the different technologies, and integration, more importantly, into their workflows, redesigning their workflows to make the most out of the different technology applications that they're investing in. Of course, when you talk about infrastructure, you cannot underestimate the reality that there is an exponential growth in the need or demand for bandwidth, right? And we've all experienced this. So again, we try to point this to our members and help them future-proof their infrastructure before they invest in it, and find that by the time they've done their investment, it's not capable of supporting the needs of not just 2 years down the road, of 6 months down the road, right? So the other challenge that we've learned about was how can I select from available technology solutions? I'm getting calls from vendors right, left, and center, and I don't know how to evaluate them. So we created technology planning and selection tools, providing guidance and framework to help providers select the most appropriate technology application for their care setting, for the population they're serving, and for their needs in different sort of genres of technology, starting from electronic health records, all the way to social connectedness, to safety, and so on and so forth. Each one of those tools has, again, a theoretical background with information about cost effectiveness and efficacy, and so on and so forth, to payment models and reimbursement streams, all the way to how to create a multidisciplinary planning team, how to plan, how to evaluate sort of bids from vendors, how to shortlist and come up with only the vendors that sort of have the functionalities and features that you really need. Of course, when you talk about technology, you should be raising awareness to the rising cybersecurity threat. So again, we developed resources around that. Especially, again, we sort of beefed up this offering with the increase of the use of voice-controlled devices, right? Like the Alexas and Google Home. And we provided specific dedicated guidance on these. We included a self-benchmarking questionnaire to help them identify where they're lacking and how they can shore up their data security stance. Again, when you talk about technology, you cannot sort of underestimate the need for increasing your technology support and training for the actual residents, right? Again, not all of your residents are born with an iPad in their hand or an iPhone like the current generation. And they may need a little extra sort of care and love, right? So that's where we are. We also encourage our members to, we feel that the gap really is in innovative business models. And we're encouraging our members to experiment in this area, whether it's through participation in innovative delivery models from CMMI coming out of the CMS Center for Medicare and Medicaid Innovation, or partnerships with payers, especially Medicare Advantage, for example, or managed care. And we're emphasizing the importance of the objective assessment of the impact of the technology or the delivery model, or both actually, on quality and cost measures and ROI, or return on investment. And we're encouraging them to document these in case studies written from providers to providers, rather than just peer-reviewed papers, which do not sort of make it to the operational level at long-term and post-acute care. And we have collected over the past few years over 120 of these different types of case studies. Finally, we do advocate for technology, both at the regulatory and the sort of legislative levels, whether it's health IT, meaning EHRs and information exchange, telehealth, affordable broadband, and so on and so forth. So with that, I'm going to stop here. I just wanted to make sure that you have all these resources, all this background, and I'm happy to answer any questions and dive into the discussion.
Can you go back 2 slides real quick? I was trying to get the research title.
Which one?
Slide 30, please.
This one?
2 more back. Yeah, that one.
You have the PDF, by the way. I shared it. I don't know if Emma or Radhika posted it, but you have all these hyperlinks.
We'll make sure that they end up in our resources tab at the end of this presentation.
Okay. Great.
So, Majd, I have a question for you.
Or I'll stop sharing. Hold on just a second. Go ahead, shoot.
Great. So my mother spent the pandemic in a CCRC, pretty near you in Metro Washington, D.C. And of course, they went into lockdown, and she experienced a year plus of social isolation and all the comorbidities associated with that. Can you talk a little bit about what learning has transpired through the Leading Age membership over the course of the pandemic, and how technology has met and maybe has not yet met the challenges of the pandemic, and what you've learned to go forward?
Absolutely. So many of our members, as I mentioned on the previous panel, where I was just a regular participant, we have seen a significant, over the past few years, even before the pandemic, we have seen that social connectedness and engagement technologies have sort of enjoyed a much higher embracement and adoption rate than many of their needs-driven predecessors of technology, right? So with the pandemic, actually that increased the steepness of the adoption curve. And many have had to quickly pivot and deploy any kind of technologies. The other thing that we've seen is that many of those social connectedness technologies found innovative applications for virtual visits, for telehealth, right? What I call telehealth light, right? Many of those technologies were essential to keep the connection between the older adults and their family, but also the older adults and their peers who may be living in the same campus but locked down in a separate building, and was also a lifeline for activity staff who were sort of charged with conducting group activities or even one-on-one activities that they no longer could safely do. So again, I believe that the sort of providers were adept and pivoted quickly, the vast majority of them at least. The challenge that we probably all faced, right, was again the demand on the step increase in demand on bandwidth. All of a sudden, everybody is using video conferencing. All of a sudden, the residents are not just using technology for their own entertainment like Netflix and so on and so forth late in the evenings, but throughout the day. So many have had to upgrade their ISP connection. Many have had to even consider upgrading their infrastructure, their cabling, replacing it with fiber and so on and so forth. And many of them could not, because of the lockdown, they could not bring contractors into the buildings themselves, right? And do those needed upgrades. Another challenge that we saw is mainly in the affordable housing. Right, the population that could not afford to have the connectivity on their own, and were not familiar with subsidy programs like the Lifeline program, right? Another sort of as a result of the pandemic, we've seen significant interest and adoption of a myriad of technologies that helped with infection control. Ranging from early surveillance, clinical decision support modules within the EHRs, all the way to kiosks that use face recognition and QR codes to allow, and temperature screening and sort of administering screening surveys to your smartphone by reading the QR code and then inputting on your device rather than touching a touchscreen kiosk or the keyboard on a kiosk, and so on and so forth. So a broad array of those types of technologies were adopted.
Thank you. That's very thorough across the spectrum. Are you planning, or are you aware of anybody who's planning to actually publish a synopsis of these learnings and discoveries? Because I think it would really add to both the contemporary and historical record.
Well, I wrote an article and was interviewed a couple of times by industry, trade, and industry publications. We are also going to be working on and adding a new selection tool around infection control that's going to be coming in 2022. And we added those two categories actually to the latest survey of technology adoption. So if you go back to one of the links, you will see how many have. Historically, we haven't tracked this, so it's going to be the first. You would see it as a blip because we have not had it on our radar screen previously. But there was a significant adoption of social connectedness technologies. Actually, for the first time in since we started doing this in 2012, it came in second place after EHR and infrastructure. Those were the two that always sort of traded first place. Others?
Well, I guess that's kind of the silver lining of this whole thing is, getting the technology where it needs to be for further innovation. I do a memory screening test to help detect Alzheimer's and dementia early, and not having the training or having people know how to use these devices where this newer technology is really a big problem. And maybe getting people set up on an iPad and getting them connected to the internet where they can access these newer technologies is going to be helpful going forward.
Absolutely, because you wanna sort of. Are they slow to respond because of a sort of cognitive issue, or because of user design interface, lack of familiarity with using the device itself or the application? Absolutely. Others, I would love to hear what you're working on. We've heard from Curtis what he's working on. I would love to hear what you're working on. We still have time. If you don't have any questions for me, of course.
Well, nature abhors a vacuum. So let me share a little bit about the work that I've been doing since working with you folks at CAST 2 decades ago. As I said, I've always looked for a way to democratize the technology. Back in the good old days, the person who created the data owned the data. One of the big paradigm shifts in today's world is that the data is owned by, some people. We don't even know who owns the data, but it's shared broadly and not necessarily for our benefit. So what I wanted to do is I wanted to create a telecare app that would monetize people's virtual caregiving on a peer-to-peer basis and monetize it in a community currency through a time
like a time bank.
Exactly. So that's what we did. We started with a commercial IoT system, and we found that it was not at all elder friendly. In fact, we had a pilot running. We have a pilot running during the pandemic, and as batteries ran down and so forth, elders couldn't replace them themselves, and we didn't want to go into people's homes during the pandemic. So we ended up developing with the NAM Catalyst Award a custom sensor technology that uses the latest Bluetooth 5 long range capability, which we've demonstrated has whole house sensitivity, and took a minimum viable product approach, looking for a couple of daily activities that we could detect, and by detecting their absence, see that there was an anomaly and use those anomalies to raise alerts. And when an alert is raised, let's say a person doesn't take their medications on time, or they're not eating, they're not opening the refrigerator, rather than a PERS system, a medical alert button where you have to push the button to get help, help comes when nothing happens, literally. And so the participants all have a very simple app on their smartphone that shows them at the center of their care circle. Let me see if I can pull it up on my phone here. Here's my group.
Yeah.
And it's a little out of focus, but there I'm at the center of my care wheel, surrounded by my friends and community, one of whom you can see has a red alert. And if I tap on his picture, I won't bother with doing that right now because there are other people who are also looking out for him, but we would see what created the alert. And if there is an alert, there's a call button. You can just tap and call and check and see how the person's doing. And if they answer the phone and say, oh, I just forgot to take my meds, okay, no problem. Actually, this creates something called positive peer-to-peer pressure that encourages people to be more diligent about taking their medications on time. So it's an aid in medication adherence. But the whole thing is to create a peer-to-peer network within the community that supports people who want to continue living independently by living more interdependently.
Right. Absolutely. Great. Others? Either ask me a question or feel free to share what you're doing.
Just curious, like as to how is the cost covered for this?
The cost for what? Is that a question to Claude?
For both of you, in fact, like, you know, who's covering the cost for implementing this technology? And
which technology though? So providers, I talked about a lot of technologies or a lot of things. In many cases, it's the care provider who invests, for example, in the infrastructure, right, in the piece of technology. But what is not covered is the interventions, the time that the professional caregiver sort of takes to look at the data and take the action. So we're seeing some of these now currently being reimbursed under Medicare, or especially under Medicare Advantage, by Medicare Advantage plans, right, as an ancillary supportive care. We also see some managed care providers willing to cover some of those costs. A third category is where they have, if the patient is a nursing home eligible and lives independently in a state that has a Medicaid waiver program. So they need to be also poor and eligible for Medicaid. And the state needs to have a Medicaid waiver program. And there are, like, for example, 16 states that would cover under Medicaid waiver programs, telehealth, biometric telehealth. There's one state, I believe, that has the activity monitoring reimbursed in Pennsylvania specifically. So it really depends. In continuing care retirement communities or lifetime communities, usually it's a private pay, right? It's the individual pays a monthly fee to live in that community in return for the care and support that they receive from the community. So it's already baked into, and if the provider opts to deliver that care, it's usually baked into their monthly fee.
I see.
Hope this helps.
So the insurance agent. Yeah. I was just wondering, like, what would it take for the insurance companies to like reimburse for the cost that is involved? Let's say people want to stay in their homes and not go to nursing homes or, like, you know, special community homes.
Large scale cost effectiveness studies. And that's what it takes.
Yeah. Great talk. Thank you.
Right. One of our advocacy efforts recently, again, we've seen that there was a significant increase in the utilization of telehealth under the pandemic when CMS waived the restrictions on delivering telehealth to the patient's home, when they waived some restrictions on certain applications that did not meet HIPAA compliance, right? So, and we've seen at the same time a significant increase in patient satisfaction and patient outcome, improvement in patient outcomes. So we're advocating with CMS to not just extend those waivers, they call them waivers, the waiving of those restrictions, but to also expand them. For example, making a telehealth nurse eligible for reimbursement when they do remote patient monitoring of individuals with chronic diseases, rather than just reimburse the physician who oversees the nurses, because the nurses are the ones who are reading the data. They're the ones who are calling the physician and asking for medication titration or change of medication, or recommending that they go see the physician, whether using video telehealth or in person, right? So, so it takes also some advocacy. So we're advocating with CMMI to launch large-scale demonstration projects with those sort of additional innovative payment models, and prove that there is both quality and patient outcome benefits, as well as savings to Medicare. And if these two goals are met, we want their commitment to make those payment models permanent models, as opposed to just demonstrations.
Mm-hmm. Yeah, that makes sense. Yeah. Thank you.
Sure, my pleasure. Others? Radhika, I think we have 3 more minutes, right? 2 more minutes.
Oh, we actually have 10 more minutes, so you're free to continue the conversation.
Okay.
Our
I'm
next
here.
activity will be the poster hall, so there's no hard stop for us over here.
Okay, I'm here for as long as you need me. Roberto, we haven't heard from you.
Hi, I'm visiting, listening all your interesting comments from Mexico.
Great, glad to have you. What part of Mexico?
Mexico City. Well,
Mexico City.
I'm a health researcher. I work on oral. I am. My background is dentistry. And I find very challenging the issue that oral health is often considered different from general health. My work line, my research area topic is oral health and frailty mainly. And our findings and global findings point that oral health is actually associated with general health among older people. But one of the main parts is
and cognitive health, by the way.
Sorry?
And cognitive health, by the way. Cognitive decline can be caused by lack of hygiene, dental hygiene, and dental care.
I have a very polemic position about that, because I think there are we dentists are working on several justifications for these associations, because as an epidemiologist, association doesn't mean causation, and further paths should be fine. But one of the issues that is absolutely preventable is dental decay at earlier ages, and this points into I will try to be brief, and this point into dental public health education. If we achieve making the people more concerned about their oral health, they will be able to keep their teeth and keep a healthier mouth longer in life. Therefore, they will have access to a wider variety of food because of the functions of the mouth during their life, and they will be in a better nutritional state longer. Therefore, it is the opportunity to have some impact on general conditions, on chronic conditions such as diabetes, and maybe even cognitive decline. But there are some studies pointing that cognitive decline is also associated with earlier childhood IQ. And this is challenging because this is also a social phenomenon. But I am interested listening to all of you and wondering how to perform and how to propose something that have a short-term impact on not only in the people, but also in the society, and even the culture of the people, in order to the people to improve the way they see themselves, they perceive the parts of their body, and take care of themselves, which is, I think, somehow beyond just technology. I love technology, and I think it's a great idea to land a lot of information for the people. But the challenge I can identify is how to make this relevant information interesting for the people who are used to be the way they are. And I'm sorry, I think this is a lot of jiggling.
Yeah, it's really challenging, really interesting, but really challenging for several reasons. Again, as you indicated, dental care and dental hygiene and education about it should start from an early age, and not just for the family, right? Starting with the parents, as well as later on in the individuals themselves. And number two, you need really longitudinal studies, right? To see and compare those that receive the education versus and implemented the recommendations versus the ones that did not receive it, or received it but did not act upon it, right? And the implications at a later stage in life. So I don't know how you can do this unless, again, this is the engineer in me talking, unless there is a simulation model, right? You really have found the causality and built a simulation model where you can again, it's simulated, it's theory, but it needs to be put to the test. But that's one way to put it to an accelerated test and see the impact, potential impact.
Yes, I absolutely agree. There is a few build cohort studies going on around the globe with very promising data. However, the older group is about 40 years old yet. So they are kind of children. They are really young yet. But the data gathered from there is really, really promising on this point of view. However, there is an additional challenge that is, I don't know how to say this properly, but the speed, the word is spread. Because this point of view is really interesting and I find it promising. However, traditional points of view remain and are so difficult to tackle and to modify certain mindset for actors at global level.
Yeah, I agree. I think what you're talking about is more like a public awareness and public public opinion campaign, right? And I believe that it should start from obstetrics, the clinicians who work with the mother and the father, obstetrics, pediatricians, and health authorities and public service announcements. If you bring those 4 or 5 stakeholders to the table and convince them that this is something worthy of investing a little, right, in terms of brochures, in terms of educational materials, in terms of short, brief, but poignant public service announcements, I think you can achieve that awareness and at a larger scale, right? In a relatively short time. I think the challenge is going to be for rural areas where people still give birth without without a physician or without a doula, right? On the farm. How do you get to those populations, right?
I think that is what I mean. I'm aiming to mean that when I say that at a cultural level, a modification at a cultural level, because we can somehow easily change people education, but this is person to person.
Yeah. I hear you.
Somehow it will be easier social education because we have access to urban areas and we can implement procedures and public health education. Public health education in urban settings, but how to make it further at a cultural level when a country as a whole accepts certain things. However, and I find this fascinating because this is also challenging on how people learn about their life experiences and their elders, because we learn so many things by culture, and we learn that our grandfathers were edentate, and we can expect to be edentate at older ages. But how to modify this? How to modify the previous experience of people? But this is kind of philosophical, not so practical. And but I think, and that's why I go back and wonder myself how to take advantage of technology to modify this. For several years, I have said, we, the health world, have the information about what is the best for the people, but we have not the budget from the larger companies for marketing this, and we find not the proper way to marketing health.
Yeah, I don't think it's a marketing. I don't think it's companies marketing. I think it should be I think a partnership, personally, between the telecom vendors, because this day and age, almost everyone, regardless of where you are, almost everyone has a cell phone, right? Isn't that true also in Mexico?
Well, it's a large amount of people with cell phones around here, but yet there are some areas with no cell phones because there are no signal
coverage. No coverage.
No coverage.
Yeah. So again, though, for those at least that have a cell phone, right? If the public health authorities can develop effective and brief messages that could be sent over simple SMS, short text messages, right? I believe this could be effective, and I believe that this is an approach that is used actually in India, sort of to sort of make public health awareness and make them aware of vaccination campaigns and so on and so forth in India. So there is a lot to be learned from the Indian experiment.
Excellent. It's great, and I know there is some ways to use, and one of the main changes you have made in me in this moment is to modify this idea about marketing. Instead, I will look for developing my skills for negotiating and achieving this sort of collaboration with industry, because as it is real, and that is they have access to a large amount of the country, and not only Mexico, but and how to partner with them in order to plant some sound information.
Well, again, with corporations, money talks. So, so I think the Ministry of Health should make a contract with them, right? Because when they deliver a message free without deducting from your message, the messages that you pay for, right? Someone has to pay for that. So that payment should come from the Ministry of Health, for example. So it should be really a partnership, a three-way negotiation between you and the health authorities, right? It doesn't necessarily need to be at the highest level. You could start small, right, on a regional basis with local service providers, local telecom providers, and do a pilot there, and then take it to scale if it's successful, and demonstrate that more people are taking care of their oral health and are starting to see benefits on whether it's cost or health outcomes. Then you can take it to the next level, maybe a larger region or even nationally.
Excellent.
I hope this helps.
Thank you so much.
Absolutely,
it's great.
my pleasure.
Thank you so much.
So Roberto, I'd like to share a little anecdote. Before I got into gerontechnology, I was working in dental and medical imaging technology. And about 3 decades ago, Fuji in Japan came out with their first intraoral camera. And they were selling this as a research tool initially, and they had a very, very small market. But somebody figured out that this was a great way to sell dentistry. You know, when you can illuminate the dark recesses of the mouth that people don't otherwise ever get to see, it really changed people's opinions. You know, a picture's worth 1,000 words or maybe a megabyte. But given the fact, and these were very expensive cameras back then, it was not trivial. You had to use optical light pipes to get enough illumination, and CCDs were very expensive. Now these devices are ubiquitous, they're cheap. You know, I don't know how much intraoral cameras cost today, but putting these in the hands of clinicians and showing people, and maybe even using some social media to share people's images before, during, and after treatment or protocols, this would speak to people in a language that everybody understands. So, you know, take what we already have in our hands and figure out how to use it socially.
Absolutely.
Thank you so much.
I think another comparison could be a picture between just like the smoke cessation ads, right? A picture of a healthy lung and a picture of the same age person who smokes. Maybe someone who's taking care of their hygiene and dental care, and on someone the same age who has not been, right? And sort of sending those as part of the public awareness campaign over cell phones.
Let me share you a kind of fun anecdote, not of mine, but there is a dentist who is attending only aesthetics for young people. And suddenly he receives a 95 years old man. He asked, "Why are you here? I do only treat young people, and I do only treat because of aesthetics." And the older man says, response. You know, last week I attended the funeral of my friend, and he was laying there in the box, but somebody left of him a smile, and he has an awful mouth. I don't want to be laying in my box with a ugly smile. It's a very fun, for me, it's a very fun history, but it is also kind of sad because people worries about how they look like, not what they can do with their mouth, like eating properly.
Right.
And this is happening nearly the end of the life of this older man, because he's 95 years old. And I don't mean that's the end of the life, right? There are people living longer than that. But he attended to the dentist at 95 years old because of the way he will look when he will be there.
Yeah, and this is a small fraction of the population that you can impact, right? Because he can afford it, right? He can afford to have an aesthetic dentistry procedure at 98, yes. Right? So,
and that's part also what I'm trying to work on my daily basis. Maintaining a healthy mouth is cheaper because of hygiene practices, but fixing what has been bad, what was been missing, that is expensive. And how to land this message in order to people to take care of themselves earlier in life.
Yeah.
But thank you so much for listening.
Absolutely. Absolutely. My pleasure.
That would be a great message, Roberto, to put on social media. The example that you just talked about.
Yeah.
Yes. I will work on shortening the story.
Yep.
Yeah.
Excellent. Radhika?
Yes, well, thank you all for participating. It was wonderful to listen in on this conversation. If I can direct you guys all back to the 6Connects platform where you can enjoy the poster hall. I know Claude's posters in there if you'd all like to go take a look at some of his work in a little bit more detail.
Excellent. Nice meeting you all. Thank you so much. And I hope this was helpful.
Thanks, guys. Good meeting you all.
And congratulations to all the winners.
Thank you. Bye-bye.